want to introduce Dr. Yasir Qazi. And there we go. Dr. Yasir Qazi, local transplant nephrologist. My friend, thank you for coming in. This guy is one of the busiest guys I know. Every time I've sat down with you, and by the way, guys, you're gonna probably hear I don't know if it's on or not, but
it is on in case I'm on call.
Usually I hear bing, 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 and it's like many life-saving decisions, life-prolonging decisions, I should say, that are hitting his phone on the regular. I met you, 2-3 years ago at some of the local conferences, and an hour, and get ready, strap in, an hour, you taught me more than I had ever heard about transplant over 2 decades of, over 2 decades of a career in nephrology, in dialysis. So I really appreciate the passion that you have. I gave a comparison earlier to, and I know Myrna, she was talking about football and scoring touchdowns as kind of an analogy of winning for the patient. But when it comes to transplant, this guy is a Kobe Bryant of transplant nephrologists, putting up numbers, getting it through the hoop, and doing things that people are taking notes on. So again, thank you for joining us.
Yeah, of course. Thank you for having me, Michael. Yeah, of course. And again, it's just really great to be back here. Myrna, that was a great talk, and congratulations to all of you guys being here on a Saturday morning, trying to get educated, because we're only as good as we try to make ourselves. And there's gap in our educations, and I love the theme of your entire presentation today. So I'm going to try to cover some of the gaps that I feel exist in kidney transplantation. And what can be done as providers, as patients, or just as community members. And here we are talking about how we can kind of like prevent this sort of like takeover that happens when people switch insurances. And honestly, as advocates for this space, it's something that we should seriously take a look at. And again, it's just happened while talking to you, and this is why I feel like such good things happen when I hang out with you, Michael.
Thank you.
So basically, these are my disclosures. I always like to start out by showing you guys a picture of my esteemed, very brilliant man, Dr. Smograjewski, who's a transplant nephrologist at USC. He's so smart that I usually go and run things by him, and I call it the smog check. Everybody calls him Dr. Smog, which is so ironic being in LA. But this is the Polish soccer team getting scored on, and why would Dr. Smog be happy that, his beloved, Europeans, they love their soccer. Why would he, in any circumstances, be happy that his country is getting scored on? That's because the person that scored that goal, number 17, is a recipient of 2 kidney transplants. One from his dad, one from his mom, and here he is, like almost taking the guy's head off, and he wears a band on his allografts, on his transplants. And really kind of like his testimony to how far we have come along in trying to normalize kidney transplantation, giving people back, normalize lives of people who've gotten kidney transplantation so they can go back and enjoy life and do things that sort of dialysis might have taken away from them. So the theme today is like, what do we do to address educational gaps? Because it does directly impact. And we just talked about what can happen if somebody loses their insurance. And I want to make this very interactive. So instead of like saving the questions towards the end,
drop them
drop them real time. This is very casual. The only thing not casual about my day is when I have to go around in a half an hour to the hospital. But please, pop in questions. And, the whole idea is to kind of like facilitate any information that I can help provide during this hour. And so like what happens if you don't have good knowledge about the process? One, it impacts transplant access. And we just kind of spoke about it, what happens when you change insurance and don't know that all of a sudden you might not have access to the transplant center that is doing cutting edge or the best stuff. It impacts how quickly you get waitlisted. And then it also has an impact on how quickly you get transplanted. And then once you've gotten transplant, how long is that kidney going to last? Ideally, we have a model of 1 kidney for 1 life. the entire life. And so all these gaps impact almost all aspects in a patient who is now on dialysis. But before we go there, just to kind of address what's happening with the disease. So I call it the epidemic of Honda: hypertension, obesity, non-compliance, diabetes, and atherosclerosis. So because all these things are just going out of control, it is having an implication on how many people are now ending up with end-stage kidney disease. And this is sort of like the map of the United States. It's not any political map. This is sort of like where it is basically going. And as you can see, Southern California ranks really on top.
Yeah.
And more specifically, Greater Los Angeles area is sort of like what I call the epicenter of end-stage kidney disease. And this is right from your dialysis facility comparison tool. Funny you bring that up.
Yeah.
Because you can actually just put in a zip code and then put up the miles, and this is 25 miles.
These are the dialysis
And these are the
facilities.
number of dialysis facilities that are within 25 miles. It is insane. And I just put in the USC zip code, and 221 dialysis facilities. When we had somebody from Washington coming here as a transplant surgeon, I wanted to compare how many they had. I had to go about 100 miles or 200 miles to get the same number.
Yeah.
So basically, the number of people that are ending up on dialysis in our communities is absolutely insane. So it is really important how dialysis compares to a kidney transplant.
Go check that out while we're on, guys. Look at your city and your zip code and see how many are in 20. You can throw a rock to a dialysis center from right here.
It's right next to a McDonald's, almost always. So if you just look up Google up dialysis facility comparison tool, and then just put in the zip code. And this is where I think it would be great to like look up end-stage kidney disease insurance comparison tool, right? Like that was a brilliant idea. How do you really compare it to? So like we have to compare these renal therapies because at the end of the day, when you fail your kidneys, you either end up on dialysis or you can get a kidney transplant. So we all know, you saw the soccer player, like obviously the quality of life would be better with a successful transplant. It's a given. People can travel. People are not bound to a dialysis facility. And, you know, in some ways it is nice as well. You have a social thing. People get dialysis, you make friends, you come out, and sometimes after transplant, they're like, oh man, I miss my guys that I kind of saw 3 times a week. Yeah, but by and large, most of the people will say absolutely the quality of life is better.
Did I tell you I had a patient that when he got his transplant, he kept coming back to the dialysis center every day that he was scheduled. And eventually, you know, it's like a social worker intervention, like, we got to find you some other things to do, right? We love you, but we got to find you better things to do. And it was great to see the guy because he was so happy about his transplant, but it really was his only social interaction for so many years.
Say, man, there's already good ideas coming in, because I had a person call me and say, is there some sort of a social support network for transplant that there is for dialysis? And I actually texted our mutual friend, Mark, and I couldn't find. I'm like, oh, these are the things that we need to, so like people can have like groups they can get in and all that stuff. So again, so much that has not been done that we have to. Now, just to like give you guys a little bit of an idea about the comparison, this is how it compares to. This is like, and again, you can see this wasn't until too long ago, 1999, after the first transplant had been done like years ago, that it proved that transplantation is normalizes life. So as you can see, there's an uptick in the first 100 days, which is people going through surgery. There's a higher mortality because people may get a heart attack or stroke and all that stuff. But after that, you can see how it is normalizing life and bringing the mortality goes down. So, and then when you look at who is to benefit the most, this is sort of like giving you how many years can be gained. And as you see, the young diabetic between the age of 20 to 39 has the most to gain of about 17 to 20 years of life. So the mortality of a 25-year dialysis patient can be really high. You know, and the transplant normalizes that lifespan back to some extent. Now, there's another little thing that kind of goes with it. It's like in 1972, Congress basically felt that folks should get Medicare. So you and I are going to get Medicare at age 65. Right. A portion of our salary goes to those benefits. but Congress didn't realize how many people were going to end up getting end-stage kidney disease.
That's right.
It was like this was the only organ, like I said, that was Canadian. You get universal health coverage immediately.
Yeah.
And what they didn't realize was that the number, I showed you those numbers. And as a result, like end-stage renal disease accounts for only 1% of the Medicare population, but it accounts for about 10% of the Medicare budget.
And that's just ESRD. So
This is just ESRD. So
not
this has gone to like
PPD.
almost it says 42 billion.
Yeah.
It was like 120 billion by 2017.
Yeah.
So and as a result, this has become a really hot topic because why are so much Medicare dollars being spent? Because it's our money, right? As taxpayers, we're paying for something that only 1% of the Medicare population is.
Right.
So, it started out with an executive order in 2017, and these were the things that the executive order recognized: high mortality rates, underutilization of home dialysis, and barriers to transplantation. What I'm talking about, like we had to have more kidneys become available.
Yeah.
Now, all of that is why you've seen like the push in dialysis units to PD,
Yep.
home hemo, all these other things that are happening to reduce the cost. And, since 2017, there's been an absolute momentum. This was 2023. Congress wanted to overhaul the entire transplant system.
Yeah.
They felt that there were a lot of barriers. Following this, the Biden administration created something called IOTA, which was increasing organ transplant access model. This was based, and I'll talk about it a little bit. This was basically created that got implemented July 1 of this year. And the whole idea was to like, there were like monopolies that they didn't want to break down, sort of inequities that exist in transplant wait lists, and modernizing some of the matching. So all of these things have really gone. And what it has meant is for dialysis units, there's like a payment reduction if your facility is not at par in giving people access to transplantation. This is a actual report that my former fellow received, and he got like a yellow bar saying that your facility is not doing as well in terms of listing people and give them a state network in United States. And the impact on the payment was sort of stressed to him, and he was panicked. Like, can you do a little education for us and all that stuff? But again, what's happening is access to transplantation for a dialysis patient is becoming a big deal. So for dialysis units, they're looking at, if you had 100 dialysis patients, what percentage of them are wait listed?
Yeah.
On transplant centers, they're looking, if I had 100 patients that were wait listed, how many of them did I transplant? Like, so dialysis units are under the scrutiny for like access to transplantation.
Yeah.
Transplant centers are under scrutiny to make sure they're not discarding kidneys and utilizing kidneys that could be used. So as a result, all of a sudden there's a push to list people. And it should have been like this all along, but obviously a lot of attention. This was my patient that was on the LA Times on like how hard it is to get a patient on the transplant list. And then like the convoluted pathway on getting, and I'm going to talk about some of that. That's where I feel like education would really help, because people are not only just getting to a list late, they're also waiting along. This is like almost doubled up since this original one. People here in Southern California for blood group O for certain kind of kidneys can be waiting almost a decade, 2 years. So you could just multiply this by 2. It's what the wait times are right now in the Los Angeles area. So it brings me back to like, where are the gaps? And I think my second point, or basically all of these points are so important. One is the fact that, when people end up getting on dialysis, they stop seeing their primary care physician because they are like so busy with their dialysis schedule. Where are they then going to take the time to go see their primary care?
I mean, isn't some people think that the doctor's the doctor?
Exactly.
I saw the doctor.
So they don't want to then see a doctor. See their own primary care. And the dialysis teams are so busy, they're like managing the dialysis. I feel there's a delay in these folks getting routine cardiovascular testing done.
Okay.
Almost none of them are like aware of like how frequently they need to keep up with their cancer screening. So they haven't had a colonoscopy done. They haven't had a mammogram done. They haven't had a pap smear done. So all these things are like things that delay in their ability to get listed because we can't transplant them
without having that done.
Yeah, so we have to then be the primary person. So
Yeah.
even though I'm a transplant nephrologist, I think I spend more time first doing primary care stuff, then doing nephrology stuff before I do transplant stuff.
That's interesting. You know, I definitely want to hear from. Drop that in the comments if you're in a dialysis center. Are you seeing that your patients are having all of these workups, or is it when they're looking at being listed? Is that when it happens? And I can't help but think about just a normal doctor's office, and you know, let's say, does the doctor, you know, check the insurance? Does the doctor check the patient in and do the routine type of assessment, or does the doctor do what only the doctor can do? So what I'm hearing from you is that you often face things that could have been done in advance. When they get to you, you could focus on what only you can do.
I can promise you that I would be transplanting so many people faster if some of these folks rolled into the transplant center knowing that they have had a colonoscopy done, having a mammogram. And I'm going to show you the workup that it is. And if there's a student that's out here at 8 in the morning wanting to do a project, I think it would be a great project between the transplant center and a dialysis facility. If there's a dialysis facility that wants to do a quality improvement project, I think, you know, you'll see how quickly your patients will get listed because you are getting dinged for not having enough people. It's not just good enough that you have referred them over. You have to now be, both the transplant center and the dialysis unit has to have a partnership that, yes, this person's listed. And like, you will see the delay as a result because I can't get, I have had to like give up colonoscopies and do the Cologuard just to get somebody listed.
Wow.
You see what I'm saying? And I think these are the things that I feel like is a big education gap that exists not at the level of the patient, but also at the level of the dialysis unit. So it's delaying the pre-transplant workup, especially cancer screening. You know, primary care is still important. Like the original diseases that fail their kidneys are going to be the ones that are going to fail their transplants as well. And then one of the other things that I feel is like people think that they are listed and that's the best thing that can happen to them, that they don't explore the ability of multi-listing even in the same city. And that's something I want to talk about in a second. So first things first, when does my wait time start? When does a person start accumulating time on the wait list? Fortunately, again, Los Angeles was sort of like so many other things, you know, LA did it first. We went by, when did you start dialysis? Before that, it used to be, when were you referred over to a transplant center? So somebody could have been on dialysis 10 years and they got referred over to a transplant center. Their time started then. It was insane. When you know, 2006, 2007, that's the way it was. And I think 2009, Los Angeles went to say, no, give them credit for how long they've been on dialysis, create a little bit of a ruckus, but all the transplant centers agreed. We felt it was the right thing to do. And then the country adopted that. Like now it goes by when someone went on dialysis, you get credit for that. But if you are not on dialysis yet, and your kidney function is less than 20% or 20 ml per minute, you better have a copy of that report and go and get listed. They will put you on what is called an inactive status, but you will get credit for that. So people have to know the formulas, what we call the GFR formulas, that will give you, it now shows up because people are asking, you know, physicians, what's my GFR? So if it's less than 20, you can start accumulating time. It's like I explained to a patient, you go to a store and you get that ticket number. You don't have to get, you don't have to buy, but you're already in line.
That's right.
And you can go shop, but you are already in line. Get that ticket. Now, one of the things that has happened in this, we've realized, because, you know, the E of the GFR it's an estimate. They came up with a mathematical formula which factored in all these things, age, sex, race, creatinine, to come up with an estimate of what, otherwise you have to inject something to see how quickly it came out of your kidney to get an actual GFR. So these are all estimates. And what we realized, some of these formulas were a little bit of underestimating how bad the kidney function was for African Americans.
Thank you.
So as a result of that, you know, you see the red and the green bar. As a result, it caused a little bit of a disadvantage to the patients. And so if you're African American and in the past you had an EGFR, which basically had a race-based formula, so going back, you see how it is a race-based, and you now can show that your kidney function would have been less than 20 if you used a race-independent EGFR, you'll get credit for that time.
Oh, wow.
Matter of fact, it became a big deal. It was in the news. A race-based test kept a lot of African Americans. So, the transplant community went back and made that adjustment. And as a result, between January 2023 to mid-March, about 14,000 African Americans got listed, about 3,000 transplants happened. So again, if you didn't know, you would have missed out on it.
Yeah,
Yeah,
absolutely.
like that rap song goes, if you know, you know.
Yeah.
You have to strive to know, right? And the good thing is we're living in a time where information is out there, but it's sometimes really hard to get that information. So again, we're still in the process of right now. I'm walking you where we feel the gaps exist, and most of the time, the transplant centers will transplant unless you have a major contraindication. What is the major contraindication? This is the list, but I basically like to always make everything into a fifth grade, picture. And here is so I give this to the patients. These are the tests that you basically need to make sure from a cardiovascular standpoint, you're good to go. You're not going to have a heart attack. You're not going to have a stroke. Remember that curve that I showed you of the initial mortality? Yeah. I want that to not even be there. So these are the things that you would have to do. And again, that it's not as a steep a rise because it was a paper from 1999. So the mortality isn't as much. Okay. No, but to do that, we want to make sure that you've had a cardiac testing done. And the number one cause of people dying after, the number one cause of people losing the kidney transplant, the number one cause of transplant center losing a transplant is because of losing a patient. They die with a transplant. Yeah. So cardiovascular disease is the number one killer in dialysis patients. So you automatically, I feel, should be seeing a cardiologist. Every dialysis patient, in my opinion, should be plugged in with a cardiologist. And again, you may not have to see them every year. You may have to see them every 3 years. But folks have to have cardiovascular assessment, risk factors done. And this is, again, to my point. I can't list these people because these people have never had an echo. Right. These people have never had a prostate blood test, never had a colonoscopy done. If these people rolled with some of these things, I will transplant them, as quickly as I can. I will for sure list them far more.
What does it take when somebody
what a great
comes
question.
in?
I knew you were going to ask me this. Yeah.
What's the time? Like how much?
It can take anywhere from a young person who, because again, a lot of this is age based. You and I were talking like, seeing a doctor and all that stuff, or at age 45 now you need a colonoscopy, right? Folks don't get a colonoscopy, right? So then for me to schedule that test with a gastroenterologist, it can take anywhere from 3 months to 2 years to get anybody on the list.
Yeah. So, oh man, that's just crazy. And Dr. Qazi, maybe you've got it in here, but life expectancy when you're sitting on dialysis, where are we sitting at today? When you're sitting on hemodialysis.
I have to go back and look. There's been improvements, but still the mortality of a 25-year-old that is on dialysis, you can compare it to somebody that's 65 and older in the general population.
Right.
So these are things that basically keep evolving and changing, and the USRDS comes up with data every couple of years. But again, these are things. I think there's something called a transplant center effect that just by referring over to a transplant center and them getting checked out, we find so many things that has an advantage. So even if they didn't get a transplant, they ended up detecting a renal mass that got assessed, which would have not been detected, or a cardiac risk factor that they could have had a heart attack or something like that. Again, we know the dialysis units see what percentage of their people die within 1 year and all that. So that's part of the dialysis facility.
So let me ask you another question. So if I'm sitting there with whether it's on dialysis or just been diagnosed as CKD5, and I'm seeing my primary, is this the status quo that they're going to run me through all of this now,
Then by and large should be, because primary care are supposed to do cancer screening.
regardless of age?
They're supposed to, yeah. So they should be, hey, every primary care has to do like a cancer screening, right? Like, or like vaccinations, like HPV vaccinations, things that they will talk to, but they'll do a pap smear. They'll counsel you on all those things. So, so cancer screening becomes a really important part of what a primary care physician does. The recommendations are. So that's why I feel like just a simple thing of having people plugged in with a primary care, then maybe you're absolved with not having to do all these things. But as a dialysis unit, if you are now their designated primary care, because the number of times when I ask a patient who their primary care is, they will always say it is a nephrologist. They'll always name the nephrologist, right? So then I don't know how seriously the nephrologists are taking some of them. Clearly, the amount of work, if you ask my coordinators how much cancer screening they do, it's like a gap that is not being met that would go a long way. And so I have this list for men, I have this list for women, like, pap smears, colonoscopies, again, something that, is important for us to recognize. And, the problem is here in Southern California, our patients are waiting so long that a lot of these tests actually have to be repeated.
Oh gosh.
In the Midwest, people can get a transplant, let's say within 4 years, 5 years. So their cancer screening might be up to date. So there's unique challenges that the Southern California ESRD patient has. And it's like being on dialysis so long. Now you have a fistula. Where do you think all that blood goes? It goes to the heart. So you have pulmonary hypertension. That's, some of my colleagues that come to Southern California, they've not even seen any of these things. I have to like educate them about, oh yeah, this isn't Wisconsin anymore where, people get transplant 2-3 years. Do you have a fistula for that long and that much? But there's going to be consequences. So a cardiovascular assessment has to be done and all that stuff.
That's a great point that I'm not sure that everybody is aware of, that, the actual demand and the demand for the change in the demand for blood, right? With a fistula or a graft.
Right. Yeah. I mean, that blood, nature didn't intend us to have a fistula, right? So you have a fistula, all the blood is going somewhere, right?
Yeah.
And the right heart isn't like capable of handling that much blood that is coming in.
Yeah.
So eventually, if you're fluid retained, you have that blood, you end up pulmonary hypertension, right? So that has consequences in its own. So these are things that are unique that patients need to be educated, nephrologists need to be educated, transplant centers have to be, oh, I gave them a transplant, I still have a fistula, what do I have to do with it? What's my responsibility to this? Who's owning it? So there are all these gaps that exist that eventually have consequences if you don't pay attention to it. And this is where I feel you can improve your outcomes and you can be so good because you're paying attention to it. And one of the things to have great outcomes is you really do have to be a primary care physician and then a nephrologist, then a transplant guy, and then like looking up for everything else that basically impacts.
Just I don't even want to throw my ideas out there, but I'm just,
Throw them.
with that disconnect of the primary dialysis transplant. What do you think is the solution from a system change?
So I think doing this and educating, right? Like, just like sitting on a Saturday, we're talking about it, and you and I that, supposedly know each other well, and we're realizing how much there is that we don't know that other people don't know.
That's right. Yeah.
And like, how do we connect these dots? Like, what Myrna was talking about, and the previous speakers, how do you like actually take it? And so like, until this happens in these sort of, I do the best I can in situations. I go to a dialysis unit, so I should go to more dialysis units to like explain that because it helps me. When you send me your patient, I have cut down the amount of work that my staff is doing because now you did a simple thing of referring them to a primary care physician.
Yeah.
And the primary care physician did their thing. So like, it's like and again, like I said, it's a great project to like actually, that I envision would really have an implication.
Agreed.
Okay, moving on. The other education gap that I think about is like kidney donors. And, because everybody talks in emojis now, like, you text me, you have to put a smiley face or now I hear like a thumbs up is a passive aggressive thing. So you can't do a thumbs up emoji anymore.
Oh,
it's like, I got it. This is the end.
Sorry, guys. I know that I use that one a lot.
That's like, this is the end of the conversation. We're done. Thumbs up. Let's not have any more discussion about it. It's like a full stop now. So you got to keep up with.
So it's got to be a heart.
Yeah, I don't know. All I know is there's like an education gap on the emojis as well. So to prevent that, I have my kidney emojis, which basically talk about the quality of the kidney. So there's something that every kidney in the United States gets labeled as or profiled out. It's called the Kidney Donor Profile Index, or the KDPI. And the idea was that we wanted to like see what we can guess is the quality of the kidney and how long it would last. So the lower the score, it's like the best kidney, and we anticipate, unless something bad happened, that has the should have the longest outcome, because it was a kidney from a 16-year-old who maybe got, in a sad situation, died in a skateboard
Right.
accident and didn't have any other, diabetes, hypertension.
Yeah.
But, most of that sort of is not the majority of the donors anymore. Like as a society, America isn't healthy.
Right.
We're like, the Honda epidemic that I talk about. So most of the time I get kidney offers from folks who have those things, diabetes and hypertension. And so the patient has to understand that it's like a way of how we profile. But this KDPI is a very sort of objective score based on 5-10 facts that the computer calculates. But many times you have to biopsy that donor kidney to look what it is, look at the totality of the story. Because if you're going to say, I'm going to just want a kidney that is a KDPI that is low, I just literally had this discussion yesterday with a patient and a nephrologist because of the sort of conception on some of these things. So like if you went just by a KDPI, there are going to be consequences on it. You have to also gather more information of like doing a biopsy, looking at how the kidney looks. So if you were to just accept a low KDPI kidney, you have to understand, I mean, again, the one that is happy and, is that these kind of kidneys first go to people that need 2 organs. So somebody that needs a heart and kidney, they get first dibs on it.
Okay.
Pediatric people get dibs on it. People who have a lot of antibodies because they were pregnant and they had 5 babies, so they were exposed to human tissue. They made antibodies, or they got blood transfusion. Your body made antibodies. So you get a priority because you may not get a transplant again. People with a perfect match get a priority. And then how long you've been on dialysis, you get a priority.
Okay.
So I literally have a patient that's been on dialysis for 14 years.
Oh.
And she's been activated, and I keep getting a kidney offer, and I have to make a decision. Should I take it or should I wait for a better one? She's waited 14 years, right?
Yeah.
And the kidney offers that I get, they're not that 18-year-old on a skateboard that I was talking about, because all those kind of kidneys are going to these people, right?
Yes.
So you have to like wonder, and sometimes, people are like, why am I waiting that long? And, it's because those kidneys are going to some of these people that have other priorities. So the way I explain it to the patient is there are 5 stages of kidney failure, and you are now in stage 5. With that perfect kidney, a live donor, you might move up to stage 1 and be normalized. But you have to understand, like, even if you moved a notch from stage 5 to stage 2 and stage 3, there are all these things that you are able to reduce. Notice how on the the graph on the top, there's a higher risk of having heart attack, strokes, congestive heart failure. So even if you were to move from stage 5 to stage 2 and stage 3, you have an advantage, because now we have better diagnostic techs, better therapies, that can protect that kidney from going down the CKD spiral.
Yeah.
So you have to make an assessment. Am I better off waiting for that perfect kidney, or am I better off that I may not get? I might die on dialysis. So this is where I feel like AI will help educate and make these calculations, because right now it's a subjective decision between the transplant center and the patient. We obviously discuss the patient, because, I don't want to make this very visual, and I don't mean it in any way, because over time you accumulate toxins that are not good for your body, right?
Yeah.
But then you also become a higher risk of, not having a great outcome with a transplant. So it's almost like you have to then match the healthiest kidney to the sickest person, because they're not going to be able to tolerate, or the kidney that is marginal, that has a little bit of hypertension, but you give it to somebody that may be able to be willing to take it because they don't want to wait the 8 to 10 years.
Okay.
So if you're sitting in a dialysis unit and you're wondering, how's this other guy getting a transplant before me? It's because they may be signed up for all kinds of kidneys, including kidney from a diabetic donor, Hep C kidneys. So it brings the important educational gap that I feel that patients need to know the transplant programs in the city. They need to know the transplant program they are listed at.
Right.
Because they might feel that they're listed at a transplant program, but they have to understand what is the practice of the transplant program. Are they are they taking these kidneys that others might be passing on, but are they having good outcomes?
Right.
So you have to know the transplant program. And again, you mentioned my transplant program, and I don't want to but this is our transplant program. I went there in 2022, and I'm still part time at KDPI, and I don't think we did an introduction, but I'm a transplant nephrologist. Halfway, this is sort of so unconventional, but this is who I am. I'm a transplant nephrologist at Providence St. Joseph's in Orange, California, but I'm also at Keck USC, where I'm in a part-time role. But I moved to Providence St. Joseph's, and you can see our the collaboration that we had. We kind of these are the numbers that went up. People can get hung up in how many number of patients, how many transplant people, how many transplant a center does. But that is not what I want to know if I were a patient. I want to know how many transplants did you do, but how many people, how many lives were you responsible for?
Right.
So if I'm doing 100 transplant, but my wait list was only about 250 people, I transplanted half of my list.
That's right.
Right?
Yeah.
But if somebody's doing 400 and they had 3,000 people on their list,
Right.
their transplant rate is low. So remember when I said that we're being gauged between dialysis units, how many people are waitlisted on dialysis units? And for us, how many people are we transplanting? And so what you need to know, not just the transplant numbers, is the transplant rate. What percentage of the list did your transplant center transplant, right? So that is what, as a dialysis patient, I want to know by comparing everybody that is within, how much. I mean, I want to travel. I want to go to Arizona. How does it compare? So this is sort of for example, I showed you the numbers, but I also showed you the transplant rate. So at CASG, all transplant centers have a code. As you can see, oh, it is the hospital.
Yep.
Can I just really quickly?
Just make,
Oh.
All right. Sorry, had to mute out, guys.
Sorry, guys.
That's the life of somebody that's doing such important work.
That's what transplant rate is. How do you continue to, make these transplants happen? Anyway, as you can see, each transplant center has a code. That's our St. Joseph is our code, and you can see, I showed you my former fellows dialysis compared the yellow bar and the other. So this is the same way you get on a transplant side. So again, patients have to know the transplant programs in the city. And fortunately, it is very simple. There is actually a newer one, and I'm so sorry, Morales. I'm sorry, Morales, Michael, that I wasn't able to get the most updated one, but right now, my transplant center has 4 bars and 5 years an outcome. So it's almost like you go on Amazon and you want to look at reviews. So the two things that you are looking over here is what is the transplant rate and what is the outcome. So you want the highest number of bars on both of these, right? So the most recent one has us still listed as number 1 with 4 bars and 5 stars. And so these are the things that a patient needs to look at. And this is public information. I'll share with you
was I looking at top scorers in California? Is that
yeah, that's the top scores in California.
Wow.
This is
congratulations.
Yes. That's been like that for the last 2 years now.
Yeah, congratulations to your patients.
Yeah, no, I mean, it's to all the people that send their patients, and you can actually see the blue dot. I'm kind of educating you guys on how this form actually look. It's called the SRTR, and I'm going to show that to you in a second. But this is sort of all the transplant centers, and that's the risk of dying. So as you can see, my center, the blue dot, and this is the country.
You see why I said he's Kobe?
No, I don't want to. Don't jinx me, man. Every time I show this, somebody gets admitted to the hospital. That's probably why that phone call came in.
Knock on wood here.
No, but what I'm trying to say is it is important for people to get empowered in knowing this. Where do I compare all this information? So this is the other thing where the education gap is. And again, you can, just like the dialysis facility comparison tool, you can go to the website called the SRTR, Scientific Registry of Transplant Recipients. So just Google that, kidney transplant, plug in the numbers, and you can see the most updated. And these come out every 6 months. The one that I was talking about, 4 stars and 5 stars, just came out in July.
Note on that, SRTR.
Yeah, the
Yep.
SRTR, the Scientific
SRTR.
Registry
Yep.
of Transplant Recipient,
Yep.
just like your dialysis facility comparison to.
Right.
But then there is also this really cool thing that has come up called the transplant coach, which is that's been created by a transplant patient themselves. And so these are things that I feel like will help people navigate. It used to be free, but I think now they have some sort of a charge, but they will tell you where to go and based on the SRTR. So I think I'm kind of going a little slow. I'm gonna
Yeah, that's not
you
good.
guys are okay? We're
Yeah.
okay on time? Okay.
Yeah, we got 15 minutes,
Okay.
10 minutes, let's say, so we can.
Yeah.
drop
So
in.
I'm gonna just make sure that also cover some parts of the post-transplant education, and some of that is because a lot is happening. I mean, honestly, I feel like we are in sort of what I call they used to have a renaissance. I call it the renaissance. The renal world is just
Yeah.
like exploding, and it's really some cool stuff. The biggest thing is like now they have biomarkers that are that people should be. I'm hoping they should be they know about it. I'll talk about it in a little bit, and then also understanding that there's ways to sort of now if you're out of medications, kind of like figure out ways working with the transplant center. The option of I didn't get my medications isn't there enough. There's a lot of support foundations that your transplant centers will work up. The biggest thing is that we now have the ability to diagnose injury early on, and we've done really well. As I showed you, like over time, the 10-year survival, this was a paper that came out in New England Journal of Medicine, about 65 to 70% of the people are having kidneys last 10 years, which is amazing. And a lot of this is also because, I always joke around, what is the similarity between a teenager and a transplant physician? We're always worried about rejection. But the truth is there's so many other things that basically happen that we're keeping a track of. And I feel like this is why it is really important to follow with your transplant centers.
Yeah.
And the biomarkers are really helping us out detecting early injury on. As you can see in this graph on the top, there's a rising creatinine and protein in the urine. You obviously should be getting labs frequently. You should be getting urine tests to make sure there's no protein in the urine. But by the time that has happened, the damage has already happened. So a lot of our focus is to detect a lot of injury early on. And a lot of these tests that are now available that you guys should be familiar with, the cell-free DNA, the gene expression profile, and a really cool virus, the torquetinovirus or the TTV. Just like, maybe take notes of it. It's beyond the scope to cover all of this. This is sort of a lecture. Maybe we come down and do this again. But basically, very quickly, what donor-derived cell-free DNA is, like if, let's say, I got your kidney, you donated a kidney to me. Now that kidney's DNA is different than my blood's DNA. So before the transplant, 100% of the DNA is mine. But after I have your kidney, if it's injured, can spill the DNA, and we now have the ability to detect that DNA.
Okay.
So that red cell that you see, let's say, is a cell from your kidney. Now it's broken down like the Pac-Man. It's broken. The DNA is out, and we can detect it. So because of that, we have the ability to detect injury so early on before the creatinine has gone up, and we have the ability to biopsy and assess what's going on. The similar technology is being used for a test called Carius, which screens out infections. Before, we used to do a urine culture, a blood culture. I just had a presentation at the World Transplant Congress about this. It has allowed me to detect infections that is insane that I would have never picked up and been able to treat them. So again, how do you stay ahead of the curve and pick up on injury? And again, these are small little things, but these are big in the scheme on how you're able to get to have great outcomes.
It's very predictive now. I mean, it's not just a spot snapshot of diagnostic. It's getting ahead of it, way ahead of.
Exactly. And the same thing that we now have the ability to take these biopsy samples and do sort of like what genes are getting upregulated. And you see these cool curves that can also detect if you're taking the medications and not. So it's a test called the MMDX.
Oh, wow.
Yeah, so really cool stuff on the diagnostics. On the therapeutics, I'm going to skip up a little bit on this because you guys all heard about xenotransplantation. So a lot is happening in that space. We did a study with the dialysis unit, and about a third of the dialysis units were still hesitant. And this was like really early on, and rightly so. Like 3 of the 4 patients died. Not to say like, obviously there's a lot of, the day the person died, the company raised 191 million because
Yeah.
remember again, the first 16 patients died on dialysis before dialysis got kicked in 1945.
With
So
Dr.
again,
Willem Kolff. Yeah.
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 So, but overall, I like to call it the ABCs. Managing is very easy, and I call it the ABCs. And these are the things that this is like 2 years or 3 years of nephrology and transplant fellowship in one slide because these are the things that we look at. And for the first time, my A has AI in it. So this is the place that I introduce AI for the first time.
Mm-hmm.
And the website I really encourage and recommend to everybody is Open Evidence. It's just like openevidence.com.
Mm-hmm.
And you can put in whatever you want to. You will be amazed at how it's just like I've been using it for like about a year now, or little under, maybe a little under a year. And it quickly has become I don't know how many billion-dollar industry. It's kind of replacing Chat GPT in being able to provide medical information. So
Less
it's called,
hallucination.
yeah, it's called Open Evidence. So again, anemia, AI, you cannot ignore AI. If you're a physician, you have, like everything else, you have to sort of embrace new technology. It's
Yeah.
going to come in. It's here. Blood pressure, calcium, cardiac, your calcium phosphate product, your
Yeah.
cancer screening, your diabetes, your drug levels, your electrolytes, the fluid, and then even on the infections, I've kind of made a little bit of an acronym like the viruses that were very common to,
Yeah.
and of course the fungal infections.
Yes.
There's a ton of therapies that are coming out. You know about the SGLT2 inhibitors. You're hearing about things like Ozempics, Mounjaros. They're becoming cornerstone. So a lot happening. So really exciting time. I'm going to skip through some of this in the interest of giving us some time. There's a lot of new drugs that have been approved in the last few years for the infections that used to kill people. CMV is a very common infection. There's at least 2 drugs that are here now. So honestly, I feel like we are in a really important time where we have nephrology space exploding, therapies coming in, we have AI coming in. So we sort of now have the ability to sort of fill in these gaps before and after transplantation that will reduce the disparities that exist. It is going to be an uphill task, but
Yeah.
I think like even in the communities that you and I are striving for, you, me,
Yeah.
Mark,
Yeah.
are looking to work for. And then these biomarkers, these genomics, these policy alignments, I feel are really going to help us, ultimately deliver care to people that have suffered for a very long time with very little happening. I always end my talk by thanking Tom Cruise. And I bring him up because this Top Gun one is when, some of the things happen in the nephrology space. We have ACE inhibitors,
Yeah.
we had cyclosporin, we had UNOS. It wasn't until the man decides to do Top Gun 2, like our space explodes. Like we have, these executive orders
Yeah.
coming around the
Yeah.
same time. So as a conspiracy theorist, I am convinced that, Tom Cruise had something to do with the explosion in our space. And, the future really is bright. And I've left my information over here if anybody wanted to reach out and all that stuff.
Man, I told you guys, quick fashion. How many you just said whole the whole education packed into an hour, right? The whole education as a transplant.
Well,
I mean, not all of it. I'm sure there's books and cabinets and AI couldn't even do this in that fast of a time, but so much packed in there. When you talk that last slide, the explosion, I gotta say that this is refreshing because the conversations that me and you have been having lately, just about career and career direction, and specifically with kind of where I'm at as approaching 50 and really wanting to do more. It's hard to see this complacency with keeping people on dialysis, right? And I see dialysis as a bridge. I don't know if all of you see dialysis the same way, as a bridge. Hopefully you don't have to cross that bridge or even get on the bridge in the first place, I should say. If you do got to get on it, hopefully you make it to the other side, which is where we're at today. So you mentioned the GLPs or the SGLPs, right? The Ozempics, the Mounjaros, things like this. You mentioned the new treatments for different sort of infections, the DNA assessment or the ability to detect the DNA early, executive order, that came out and everything that's in the aftermath of it. I think a lot of the commentation in today's healthcare world is around the bridge itself. You're clearly putting up numbers to show that we can get people across this bridge, that we can keep people off the bridge. Education seems to be the biggest theme of what I heard right now. For those of you who are online with us, are you seeing that the workups are being done, that within the nephrology practices or the primary practices that you're working with, are they utilizing the tools that Dr. Qazi has just pointed out to us in the prevention delay, in the actual pre-workup, so that people can, again, prevent a delay on the side of the transplant workup, that we can keep the transplant nephrologists in the zone of getting those kidneys identified. Anybody have any comments on that? Anybody want to jump in and have a question for Dr. Qazi? So I want to point out a couple comments we had, Dr. Qazi, just a few minutes ago. So we talked about the multiple listings, multi-center listings. Is this the common ground of what you're seeing today?
I think like it's such an important thing as if you're a dialysis patient that you should, advocate to your transplant centers. And I'm actually challenging that. Like, one of my colleagues, a very esteemed person, is like, there's no advantage of listing in the same city. And it's far from, and I challenge it.
Yeah.
Because all transplant centers have the ability to put their filters on what kind of kidneys they want to be called on. So, I mean, we're human, and it's not possible to like take up offer for like what we think is not even going to be something that we're going to transplant, right?
Right.
So everybody has filters. So unless people are familiar with what kind of filters they put in, you're not going to get called. So like somebody might now want to be woken up from a kidney that's in Nebraska that nobody in Nebraska wants to use, that could be shipped in. So there's a lot that's happening in terms of like centers that are what are called like aggressive centers.
Yeah.
And again, on that SRTR report, I believe it's page 13, you can look at how many they're doing what are called hard to place kidneys.
Okay.
These are kidneys that are like 100 centers or 100 people were bypassed before you placed it.
Yeah.
Like the people that are using those are actually spending the time to bring it. And Transplant Coach, that second site that I showed you, has some information. I'm hoping I have to reach out to them. I did reach out to them once, that they're not charging us some crazy amount of money because it is based off the SRTR data.
Yeah.
But those are the ways that you want to list, even in LA. You want to list in multiple centers. And honestly, it's like because I'm in Orange, and there are people that are listed at UCI as well.
Yeah.
Sometimes they transplant the patient, sometimes I transplant the patient. But I just know that it's someone has a higher chance of getting transplanted because there's so many ways that you may miss out if you're just getting listed in one place. By and large, we do have dibs on the same kind of kidneys, but like it kind of becomes a little bit tricky if it's coming from other states.
So,
And then it depends upon like what have you said? Call me X, Y, and Z. But it's it's not an X, Y, and Z. It's an A, B, and C. And the other center has said, call me with A, B, C, X, Y, Z. So that kidney comes over here. You see what I'm saying? And you get transplanted.
Yeah.
Yeah.
So bust the myth or validate this for me. I've heard that even some of the proximal states to California, that there are in some cases like really much shorter times.
Oh, for sure. Absolutely. So like Nevada, Arizona, the more Midwest you go. And again, the Transplant Coach actually gives you the list of where you are nationwide as state-wise as well.
Yeah.
So there are websites that you can go around and look around. But I do strongly recommend people be multi-listed.
Yeah.
And, some centers get offended by that. I don't. I'm like, yes, a patient should have the right to get.
Why do you think they get offended?
Well, I feel like some folks feel that like, they've done all the workup and then somebody gets transplanted somewhere else. That was a concept that existed. You shouldn't have that anymore, right?
It's a win for the patient, right?
It's a win for the patient, but then like, think about it. Like, my patient just yesterday, and we just started a kidney pancreas program as well. So we basically now have done like the second highest number of kidney pancreas at Providence and Joseph in the city. But so this patient, again, to your point, wasn't contracted with us with that particular insurance. So we're in the transition of getting him to, because he did want to come get transplant and got transplanted at Loma Linda while they were going through this. And then my coordinator had put in all this effort, like trying to do the card and all the phone calls. So the coordinator might be like, oh, I put in all this effort for nothing, right? So this used to be a concept that, we have to go away from. Like at the end of the day, you have to realize that this is what it is. Somebody might get transplanted somewhere else and you can't get, you can't take it. So there are programs that will say, no, we're not going to list you. You have to sign off from the other program. And I would challenge that. I'd be happy to talk to them, if someone's saying that to you.
Yeah, I've seen that again recently with some friends. And I can't quite get the, how you mentioned, like, it's not a waste of time. I mean, it may not have happened in your center, but ultimately, like, I have this, and I know you do as well. You just said it, is I want to see the patient win, whether it's here, whether it's there, whether it's with me, whether it's another, I'm not a physician, but another friend, if you will, like, another technician, another administrator. I want to see them win and find the right fit for them.
Yeah.
So any questions for Dr. Qazi? I think we've got a poll up, and I know that we just got a phone call, so I want to make sure that we respect your time and get you over to the important stuff, Dr. Qazi.
Thank you, man.
Not that this wasn't important.
No,
really,
of course.
really appreciate your time.
This is always fun for me.
Yep. And then just really quick, they have places for people to register as a donor apart from registering with the DMV. Do they have? And I just was made aware, I think, when we did the art show a few months ago, World Kidney Day, that you can even do it through the app on your iPhone.
You can, and then the biggest thing is to like communicate to the family, because at the end of the day, those are the things that get expressed to the family, and the family will obviously want to execute your wishes, the way you have kind of like wanted it to be.
So to register on the list, though, DMV, and then I think the health app on your iPhone, right? Is any other advices?
I actually don't know. I have to go. Yeah.
Yeah. So I check your health app on your iPhone. If you have an iPhone, look on there. You can see a donor registry there. You can sign up right through your iPhone, but DMV as well. Dr. Qazi, as always, great to see you.
Likewise, my friend.
I look forward to many more of these. I won't be at as many conferences in the upcoming days, but I'll be in the California one if you're going to be there. Look forward to having a bite with you and grab a cup of coffee.
Absolutely, man.
All right.